genetic analysis. We're trying to see how these viruses, this appears to be a pretty new epidemic, and how are they related. So sequenced the NS5B, you get the nice sequences here, and make these phylogenetic trees. And what you can see here from the different countries represented by the different colors, that there are clusters of related sequences, suggesting sort of tight transmission. And summary here is that there were overall 11 clusters, and the cluster would be the minimum of 4 sequences in this case, up to 37 different sequences. Sequences here really meaning individual patients. And then 6 pairs, so just too closely related. So 84% of the men had a Hep C strain that was similar to one other subject. But really striking, 2/3 of them had a similar strain to somebody in another country. And using kind of a molecular clock technique that is plus or minus a little bit, but trying to then look back at when you think that the beginning of this was, maybe the summary state would be the majority of transmissions occurred after 96, and we actually think most of them really occurring after the year 2000. So this is new. This is not something that we just missed before. So what are the risks? So first of all, is a group in Holland, and specifically in this study, looked at sort of a combination look at an Amsterdam cohort study enrolling men who had sex with men, longitudinally following behavior and by questionnaires and serostatus. And what you can see here, just the 2 time groupings, that in HIV-negative MSM, there was no hepatitis C incident at all in either of these time periods, while there were cases here in the HIV-infected MSM, and that looking in terms of the incidence, that the incidence increased tenfold over this period from before 2000 to the short period after 2000 in which it was looked. And where they actually had more cases were just reports from the hospitals that were reporting into the surveillance system. And just a note here that although they didn't have longitudinal questionnaires, asking, then they came in and also with the diagnosis that 23 out of the 27 either had an ulcerating sexually transmitted co-infection or had anal fisting as part of their sexual activity. So that was from the Amsterdam group. And Mark Danta organized really a big study in London and to some extent involving the Brighton groups, and used a questionnaire and did a case control study where the newly infected patients compared to people who were also in their clinic but were still Hep C negative. And it's quite a long list of the risks, but it's basically unprotected intercourse, receptive intercourse by and large. There's licking of the anus or having your anus licked. There's fisting, sex toys, group sex, and various activities involving group sex. And what wasn't associated with is basically oral sex or wearing a condom. But also looked at was drug use, and quite a number of drugs were associated with having gotten hepatitis C, and notably marijuana, cocaine, and some of the and including crack were not associated. But it's, again, a fairly large number of risks were associated with being infected. And so from those studies and a number of others that I've cited down here from a few different countries, the sense is here, and I'll show you what our study looked like and help you think about it, that a number of things are feeding into the new hepatitis C infection. And on the sex side, this is really where I want to emphasize here, because what we're interested in epidemiology, and I'm not an epidemiologist, but I'll speak for that, that we really want to find out what is actually doing it. And so we know that the drug itself, if you're not injecting, is not actually doing it. So we want to get down here to think about the risks here. But there's a lot of internet use, sexually transmitted infections. Serosorting, I think, is a very important issue. We can talk about that in whatever you want to, whatever high risk is considered. In many cases, that's basically just not using a condom. And in the interaction with the drugs. Okay, so that's sort of a broad model. So let me tell you about what I have been observing with my colleagues in New York. So here's an alphabet soup of HCV and HIV plus MSM NYC. Great. You know, it's hard to fit it out all in a title without abbreviating everything. So here's a study scheme. I have, because of the healthcare delivery system in the States, where private docs are really take care of a very large proportion of HIV-infected MSM. This has been, and I won't have time to get into this now, but if you're wondering why we haven't seen it so clearly in the United States, a big important reason. So I have a number of, basically gone out to all the docs of the city and said, if you see anything, send them to me, and there's with variable success. So this referral network, I'm going to tell you today about 53 cases of new hepatitis C infection, and then a few aspects of it. We've done a risk factor analysis on a subset, our success in treatment, and the liver histopathology that I alluded to earlier. So the demographics of 53 cases actually in 51 patients. I'll tell you about two people were reinfected in this time period. The median age is 40, very much as is seen in Europe and Australia. 27 white, 17 Hispanic, 6 black, and 1 Asian. The median duration of known HIV infection was 7 years, but it ranged from 0 to 20, meaning actually 2 people who came in the door with what we think are simultaneous HIV and Hep C infections, out to people who have had it quite some time. The median CD4 count of 471, the HIV infection is under excellent control, and fully a quarter of our group had never received antiretroviral medication because their CD4 counts were too high and it was considered not indicated. In our group, I won't show you the data, the concomitant sexually transmitted infections was actually uncommon. So essentially all of them are genotype 1, and really pretty much all are genotype 1A, which to some extent reflects what we see in New York in terms of the distribution of genotypes, but it's disproportionately enriched for that. And we have not done our phylogenetic tree yet, and we are planning to do that in collaboration with the international group. So let me tell you about our risk factor analysis. We did a similar study to what Mark Danda had done in England, and I had the good fortune of getting the questionnaires from everybody who had done questionnaire studies, and we made it sort of a New York specific one. So we decided to do as carefully as we could to try to focus a little bit more on what the actual transmissions were. And so did an age-matched study. So we'd have our case patients and then 21 HIV-infected MSM of very closely related in age. And we think age is very important as behaviors change quite a bit as you move not very far off in age. And matching that way, we had then matched the ethnicity, duration of HIV infection, CD4 count, pretty much anything else. You imagine we're not significantly different through the groups. And so this is an explicit questionnaire, sex, drugs, sexually transmitted infections, over the prior 12 months. And what have you been doing over the prior 12 months? And we come up, so this is the sum total. If you picture the Danta study that had quite a large range, we found this: unprotected receptive anal intercourse, whether or not there had been ejaculation. Unprotected receptive oral sex, so that would be penis in your mouth if you're the one infected person, was associated with being infected. Use of sex toys, and then the last two, the drug use. Sex while high in general, not a specific drug, and the specific drug of marijuana, which I can't explain to you, except for one thing here. So it turns out we had a moderate number of injection drug users. We had 5 people who were injecting from 1 to a number of times of crystal meth, and 1 person testosterone. If you remove the 6 pairs who reported injection drug use, the 2 drug use risks drop away, and what you have is basically unprotected receptive anal or oral sex, sex toys, or group sex.